I am lucky to be joined by Dr. Pemberton, Dr. Hassami, and Dr. Baseman. Today, we're going to be discussing something that is a very important topic, near due to us, but also one of our focuses on the technology that we've created. It's the Observability Dashboard in Action. We want to show how the Observability Dashboard in Action can potentially prevent poor maternal outcomes even before they happen. So I wanted to just go around, have Dr. Pemberton, then Dr. Hassami, and then Dr. Baseman introduce themselves.
Okay, well, I'm excited to be here. My first time webinar with the birth model. So my name is Dr. Nicola Pemberton. I am the medical director for Artemis OBGYN and the Birth Center of New Jersey, which is located in New Jersey. It's the first OBGYN center owned by women of color in the Northeast. And we're here trying to do what we can when it comes to improving, of course, maternal morbidity and all the issues that unfortunately that we deal with nationwide, especially locally to New Jersey. So I'm excited to be a part of the birth model, seeing what we can do to help move things forward.
Amazing. Well, I'm glad to have you here. Dr. Hassami?
Yes, good morning. I'm Sam Hassami. I am a urogynecologist and pelvic reconstructive surgeon by training with extensive experience in healthcare management, and it's a pleasure being here.
Thank you.
Good morning. Thanks for having me. I'm Dr. Deborah Baseman. I practice general OBGYN for 28 years in the Princeton area, and now I am part of a new research initiative and on the advisory board of Birth Model because I'm so excited about the technology that I just had to be part of it.
Amazing. Well, I'm glad to have the three of you here. The first question that I want to jump into is really how we can shift from reactive to proactive care. And traditionally, obstetric emergencies are managed reactively. How does real-time AI driven surveillance fundamentally shift the way that we approach maternal care? And what cultural or operational barriers exist into making that shift?
I'm going to start, if I may, Anish. In medicine, and I can tell you from my years of hospital experience, if you look at, for example, processes such as rapid response teams in the hospitals, they are systems created as a reactionary systems to jump in to help patients that are deteriorating. The fact of the matter is that when every time we review a case, we realize that there has been signs all along, prior vitals, prior shift, urine output, subtle changes in patients' vitals that we just missed. So the truth is that patients don't suddenly crash. It's just that we realize suddenly that they're crashing. And that happens also in maternal care. In the obstetric emergencies, whether it's a progression of preeclampsia, whether it's progression of intraamniotic infections, subtle changes in fetal heart rate tracing that become suddenly a disastrous situation. It's just that they've been there. And I think what AI can monitor these subtle changes and give us early warning signs. And that's how we can preemptively get involved and prevent a disaster from happening.
Can I add to that? So that is absolutely true and very important. And I think that part of the equation, besides all these subtle things being unnoticed, is that everybody's overworked. Sometimes the issues are missed because the doctor's down in the ER taking care of an emergent patient or in a C-section, and the nurses are then caring for too many patients. And so the time that besides having the predictive warnings, the amount of time that Birth Model saves by having the motherboard, the dashboard, predictive AI in the chart, in the charting, like the hours saved by smart charting are going to be able to allow also the human side of recognition of these problems it's going to be a two-prong benefit, because besides the predictive AI, I think there'll be more time for physicians and nurses to be attentive to the patient.
And then I thank you for those. And then for Dr. Pemberton, I kind of wanted to address the question towards you. I see that in general, many providers tend to be hesitant towards AI-driven alerts. I know that the Birth Center of New Jersey has recently started using Birth Model, but how can we ensure transparency in AI-generated insights so that clinicians understand not just what the alert is, but why it was triggered? And how do you think we can continue to develop it to make sure that we get the trust of clinicians?
Yeah, I think for the most part, I think a lot of us can appreciate when it comes to anything computerized. A lot of us tend to, and I always say this about neonatology, NICU nurses, after a while, you don't even hear the babies crying. So it's the same thing with alerts. After a while, you see the alerts, they come, they go, and we just kind of wave them off. We dismiss them, we pass them on. I mean, first and foremost, I think when you show that we might have a system that is going to help, not just be a bunch of dings and bells and whistles and just pop-ups, but something that actually is going to change the course of how we are managing medicine, how we're managing our patients' care. I think using this AI-driven software might be able to help, first and foremost, not be just what EMRs are out there right now doing on a basic level, as they claim that they're trying to do things to be more efficient.
Yeah.
Of course, from a administrative standpoint, they are. But what we're trying to do is merge the administration with the clinical and see whether or not this software will allow us to be able to say, how can we make this work for this individual patient at this moment in time? Those are things that grow over time the more you do it. So if you're going to be able to use things that will allow to predict the timing, being able to say we can manage this patient in a better, safer way, I mean, that thing grows over time just by one patient at a time.
Yep. And, I think kind of more on that is, I think clinicians sometimes, or even the administration sometimes gets nervous that technology is trying to replace the EHR, or they already purchased the EHR, they've already put in so much funding into it. I think it's good to clarify that birth model, what it does is it makes the existing technology smarter, more intelligent, because it's created by clinicians that are there in the field, struggling day in and day out to not have those real-time insights. I had a question that came up, how can we reduce alarm fatigue? One of the biggest issues with monitoring technology is typically, you might get too many alarms in a day. How does the observability dashboard, the way that you foresee it, and I'll leave this question open, differentiate from critical alerts and non-emergent deviations to then prevent alert desensitization?
Yeah, I think most. I guess I'll start with that one, if I may. I think most fatigue from alerts and reminders comes from the administrative parts. This note, sign this, that, so on and so forth. I don't think physicians in general get alarm fatigue when it's about safety issues and things of that sort. I mean, if it's a reminder for patient needs antibiotics, the second dose hasn't been ordered, I don't think any physician complains about that. But people get alarm fatigues when they say, okay, you have to sign here, you have to do this, you have to do that. I think at the end of the day, alarms are reminders to bring our attention to things that we might have missed. And I don't think any physicians has an issue with alarms. And I think what AI doesn't, and most alarms are triggered by a single point of deviation. But that's not how AI works. At least that's not how a birth model is looking at this. We are looking as a pattern, a trend in deviation in certain physiologic parameters of the patient, whether that's the baby or the mom. And that triggers an alarm, or hopefully that will trigger the implementation of a set of safety bundles, blood pressure changing, put a Foley in, and you're going down towards sepsis and IV fluid, antibiotics, so on and so forth. I think that's the whole point of alarms and AI in this context, not a singular point of deviation, or the blood pressure is dropping, do this. That's not what we're looking at it.
Just to piggyback off to what Dr. Hassami said, he mentioned about the sepsis part. And right now, the EMRs, I guess at the current hospital I'm in, they're generalizing sepsis, where they say if someone had temperature of 99.3 and they're just making this general statement, this is coming all the way from the ER all the way up to labor and delivery. And some of those things are not even, they don't apply to the patients we're taking care of in that moment. So this is generalized, oh, this patient has a sepsis bundle. We got to order blood cultures, and you're like, that doesn't make sense. Yeah. And so what you're saying is correct, Dr. Sami, is where we need alarm systems that are, I would say, catering to what we're dealing with in that moment. And if this is a system that we're trying to put in place that allows, okay, if we are experiencing things with this particular individual patient, we can be able to see where it's going to test, versus it being, we're just going to put some parameters here and then it's going to shoot off alarms everywhere. That even though clinicians are not going to try to shut off those things in their minds, they tend to do so, especially when they know it's not relevant to that patient, especially if we generalize, it's not related to what we're doing.
Yep.
I mean, I think the fact that birth model is dynamic and that it's based on, changes during the course of the labor, and not, as Dr. Pemberton was saying, some static model for a non-pregnant patient. We know physiologically pregnant patients, their
Too dead
all
out.
their processes are different, right? Their cardiac output's higher, their blood pressure is often lower. Like to be able to look at this in real time and trend a patient during the course of the labor, because a lot of times these changes are so incremental that, they're missed. But the other thing that, even though it's not kind of the predictive alerts that you're talking about, the other thing I really like about Birth Model is that motherboard, because there are those subtle alerts in there, like if you don't give the antibiotics, there's the red dot. So you can just look at that. I'm a very visual person, so to be able to look at that and then see the alerts at the bottom, patients' postpartum hemorrhage risk, and in the future their shoulder dystocia risk, or if they're moving towards choreo, all the different predictive measures that aren't the visual and the auditory annoying alerts, but to be able to walk in after you've been taking care of other patients and look on the board and basically see all the whole labor progress and the alerts in one place, I think is really powerful.
And we were actually discussing this before, Dr. Baseman, is one of the biggest struggles that I think we face as clinicians is that we've gone through years of training to get to the place that we are right now. And we cover, under those years of training, a lot of experience under our belt. Sometimes balancing AI with clinical judgment can get, questionable. I think the providers out in the field, they sometimes get wary. How do we strike the right balance between AI-driven recommendations and provider autonomy, ensuring that AI, in the way that it's created right now, supports, but doesn't override our clinical decision making? And how do you differentiate from a tool versus a decision?
Is that specifically
For
for me?
anyone who wants to answer that.
I think that we know everybody's spread very thinly on labor and delivery, and there are things that I think people would be grateful for the redirecting their focus or attention to a developing problem or a potential situation, recognizing that, of course, the provider, it's not prescribing what should be done. Of course, the provider has years of experience in clinical judgment, and just even going and seeing the patient gives you so much valuable information. But if you're in another room pushing with somebody or doing a C-section and you don't get that, like, oh, I better circle back there, I think that's the value of the AI, is just to refocus the attention of the labor and delivery staff when things are busy.
Yeah.
I just want to add to that. I think, if you look at the tools at physicians' disposal, whether it's fetal heart rate tracing, whether they're vitals, all these things are fairly descriptive. I think the way AI will change medicine is that it's going to make the collection of this information and becomes a prescriptive tool, meaning that, listen, all of these things have happened. Now this is what should happen, and it will happen. And I think that's where it's going to be a game changer, and that's how we can intervene much earlier and prevent progression of, we cannot prevent progression of preeclampsia, but we can intervene much sooner. Mm-hmm. A maternal hemorrhage, same thing. Sepsis. These are the top 3 leading causes of maternal death in our country. And these go through phases. These go through stages. And rarely patients just show up and they're eclamptic. Obviously, before we see them eclamptic, they were preeclamptic before the blood pressure was going up. So I think that's what AI does. And it's not that it's going to describe the patient. It's going to say, listen, this is the collection of the data in this patient, and it's going to prescribe to us that this is what is going to happen. And that prescriptiveness of AI is what's going to change, is a game changer in maternal health.
So, I think beyond that, and kind of resonating from that, is that the reason that we created Birth Model was because hospitals are, the EHRs are just deployed on instances. So they don't do pattern recognition. And as a result, we're missing the big picture, the disparities in care. We are so used to having static models and saying, okay, this patient has a Bishop score of this, Friedman's curve is going to get us to this part, preeclampsia is diagnosed by these blood pressures. But what Birth Model allows us to do is break those barriers and say, for this particular patient, these are the outcomes that we predict can happen. How can we prevent those outcomes from happening before we're too late, we're in the trenches? And so I think identifying disparities in care is extremely important. That's one of the biggest motives of birth model, but would love to just open this up to see what beyond that, like beyond the features that we existingly have, can help, identify disparities in care.
Well, I mean, for me, it's just, I guess that's daily, and it's close to my heart in that regard, that I see it. Unfortunately, again, people who come into this field are trying to do the best that they can, but it doesn't change the fact that we are just sometimes all built in with biases. It just works that way. And so in those situations, I don't think people are thinking in that moment that they are working with a bias, and they don't think that bias is going to potentially be detrimental to the individual. They may be having the subconscious bias too. But as a result of it, the hope is that what AI can do when it comes to this birth model is be able to eliminate some of those things, that if you are receiving the alerts to things that are kind of directing your steps towards the care for that particular patient, regardless of what they look like, who they are, where they're from. And you'll be able to see all these things bringing out, hey, this is the best way we can care for this patient. Hey, we're kind of going in this direction. Let's kind of start moving in a more proactive way. And it kind of will take away, hopefully, well, I didn't think it was this, and, because the patient was kind of anxious, and, we kind of, talk things away many times. And as a result, we're not doing it again for malicious intent, but as a result, because of those subconscious biases, we don't realize we're doing it, and it can potentially lead to some unfortunate detrimental results for both mom and baby if it just keeps going too far. This is where we can curtail some of those things by being able to say, here, look at the picture as it stands for this individual. Nothing is giving you anything else except if this patient, let's say, for example, is a woman of color, we know her risk factors are high. Watch what is happening here. Let's be proactive to manage it at this point, not when we are chasing our tails at the other point. Yeah. I think that's what would be the best thing when it comes to what AI can do.
That was very well said. I think
Very
to
well
Dr.
said.
Pemberton's, what you just said, to add to that, I think one of the main points of equity, or how to reach an equitable management of any patient, is to get rid of bias. And by doing that, you're standardizing. And that's the key, standardizing care to patients. And I think that's what AI does. It standardizes patient care by eliminating bias, which is a huge component that prevents us from giving equitable care to patients.
So thank you. And one of the last questions that I had for today's session was essentially scalability across diverse hospitals. AI adoption can vastly be different in a well-resourced academic center versus a rural community hospital. What challenges have emerged and do we foresee in deploying the observability dashboard in different types of institutions, and how can we address those? There's patients that are different in rural parts of America versus the urban areas that we live in right now.
I mean, I think the biggest advantage of birth model, or one of the biggest advantages, because there are many, but is the time savings for staff. So we have these rural hospitals, there's shortages of OBs and presumably shortage of nurses also, and the time that's freed up by the AI, all the measures within birth model just are going to allow for more efficient care, which hopefully will lead to better outcomes for equitable care.
I also want to add to that, maybe you're absolutely right, but to add to that, in areas that there is a lack of subspecialty care, I mean, there are areas that, you have family medicine doctors who practice obstetrics, they do OB fellowship, you have nurse midwives, and, they're going to come points where there are questions, is this a category 2 tracing, not? I mean, things as basic as that. And I think AI is going to push physicians to do the right thing more often than not. And I think that's where in rural areas, the lack of subspecialty care and specialty care is going to be more beneficial to have AI than not to have AI.
I think that's true. I think there's... Oh, sorry.
No, go ahead.
No, I was just going to say, I think there's a huge range of experience of, depending how long you've been in practice, the rare things that you may see versus somebody who's new. And I think very much what Sam was saying, like it's going to level the field and give people who maybe haven't seen that particular situation before a heads up that I need to look at this more closely, or I need to call somebody and ask them, or I need to get the next level, escalate this to determine what's going on. So I think that it will be really helpful in that regard.
Yeah, we were just about to say the exact same thing. When Dr. Sami made that point, it was like a light bulb. That is correct. People on different levels don't have the same experience. They may be looking at Google, no, up to date. And in this case,
Up to
we
date.
needed a little bit of help. I think AI would be beneficial even for the less experienced, or as we said, those who are not in the areas where they will have access to those subspecialists so easily. I think it will give them that additional support, because they're like, I don't know what to do with a patient like this. What do I mean, we don't need that as a replacement, but more of a supplement.
Yep. Well, thank you so much for joining today. We brought up some really important topics. I think we could go on and on about this topic because it is so important. But the observability dashboard, my takeaway from it is that it acts as a second set of eyes, whether no matter what type of hospital that it's deployed at, to allow the staff that's actually dealing with the issues at hand to be able to do their job without them having burnout and poor patient outcomes. I'm grateful for all the support and for all of your advisorship that's helped make this happen, and looking forward to more. Thank you so much.
Thank you, Anish.